Over time, this results in a stress response system set permanently on high alert. In the areas of the brain dedicated to learning and reasoning, the neural connections that comprise brain architecture are weaker and fewer in number. Science shows that the prolonged activation of stress hormones in early childhood can actually reduce neural connections in these important areas of the brain at just the time when they should be growing new ones. Toxic stress can be avoided if we ensure that the environments in which children grow and develop are nurturing, stable, and engaging.
Again, to echo, toxic stress can be avoided if we ensure that the environment in which children grow and develop are nurturing, stable, and engaging. And if we think of the past 2.5 years, there are a lot we experience or still experiencing that can be a source of toxic stress. Early and prolonged exposure to screen time, the prolonged lockdown, and the overall impact of the pandemic in our mental and physical health, financial security, several even experienced loss of family members, and preliminary results from an ongoing cohort study in the US showed that birth during the COVID-19 pandemic was linked to lower neurodevelopmental scores at 6 months, irrespective of maternal infection with SARS-CoV-2. And we're talking about the general population of children. What more if they have developmental disabilities? So, developmental disability or disorder are childhood mental or physical impairment or both that result in substantial functional limitations in major life activities. There are approximately 1 in 6 children diagnosed to have a developmental disorder. They were actually seen as the new morbidity of pediatric practice more than 20 years ago, and we do not see any decline in the rate. Most prevalent are ADHD and specific learning disorder, but over the years, we have seen an exponential rise in the rate of autism. It now has a worldwide prevalence rate of 1 to 2%. In the US, their latest rate is 1 in 44. Unfortunately, we don't have local data to present, but we do see a similar trend. Just to illustrate, this is the top 10 OPD consult in our general pediatrics clinic in PGH. Developmental disorders occupy 2 of the top 10 in 2011. So that was 11 years ago. After 5 years, developmental disorder occupied 4 out of the 10. ASD or autism is already in the list. And fast forward to 2022, in the current trend, developmental disorders occupy 5 out of the top 10 consults, with autism spectrum disorder topping the list. And applying what we discussed earlier, the best chance for effecting developmental changes while the brain is most malleable and responsive, which is in the early years. For at-risk children, appropriate and timely intervention can improve the outcome and their quality of life. While for those with established risk, for example, babies born with Down syndrome, early intervention may prevent secondary problems. And this is where pediatric healthcare professionals play a crucial role. They are the first and sometimes only professional the child and the family are in contact with before the child enters school. They have an accepted position of authority, and they are aware of underlying social and familial factors in the child's environment. As pediatricians, we identify infants and young children with developmental disorder through the process of developmental surveillance and screening. The American Academy of Pediatrics released an updated policy statement last 2020, and the Philippine Pediatric Society and our society, PSDBP, also endorsed the policy. To define terms, Developmental surveillance is recognizing children who may be at risk for delays. We do surveillance every time we encounter a pediatric patient. Other healthcare professionals who meet pediatric patients in their clinic may also do surveillance. If we identify a risk, the next step is developmental screening. So a standardized screening test is administered to further refine the recognized risk. And when a child fails the screening test, the next step is to perform a developmental evaluation, which is what we do as developmental pediatricians. So the evaluation will help identify the specific developmental disorder or disorders affecting the child, provide further prognostic information, and start appropriate intervention programs. But suppose the primary care provider strongly suspects a developmental disorder even after surveillance. In that case, they may refer the child right away for evaluation and even early intervention. And in the next few minutes, we will discuss in details the process of developmental surveillance. Okay. To define surveillance further, it is a longitudinal, flexible, continuous, and cumulative process in which knowledgeable healthcare professionals identify children who may have developmental problems. Surveillance aims not only at detecting delays or disorders early in life, but also to identify and intervene into risk factors for child development. It also provides an opportunity to do developmental promotion or coaching with families. In the recent AAP update, there are now 6 components for developmental surveillance. And the first component is eliciting and attending to the parents' concern about their child's development. The first rule is to never ignore a parent's concern. When they are worried, there is a good chance that something needs attention. But the absence of concern does not also rule out the possibility of delays. Parents may not tell if clinicians do not consistently ask. At times, parents do not voice concerns, thinking themselves overly anxious or thinking that it is not part of pediatric well care. When parents don't have concerns, you have to check if there are communication barriers and also determine who is the primary caregiver. And when we ask, the wording also matters. Parents respond better to the question, please tell me any concerns about how your child is behaving, learning, and developing. Some find the words worries or problems very ominous, and many were unfamiliar with the term development, but what helped was pairing learning and development in their understanding or comprehension. The second step is obtaining, documenting, and maintaining a developmental history. Some of you may still remember the table of developmental milestones that we had to memorize for the board exam. And for some, they only do developmental history until 2 years old when the child starts walking. Others who are more astute would have observed that the milestones actually differ depending on the source. The U.S. Centers for Disease Control and Prevention and the American Academy of Pediatrics have released a few months ago their updated developmental milestones checklist in the Learn the Science Act Early program, which helps parents identify developmental delays in their children. So they gathered experts in child development from various fields and came up with a checklist for visits from 2 months up to 5 years old, since we're targeting early intervention. The items included were skills expected already in 75% of children for that age. So if it is not yet present, it is already considered a red flag, which makes it simpler and helps avoid a wait-and-see approach. They also added socio-emotional milestones to the checklist. It is also very convenient. You just need to download the app for free, input the child's information, and you can already access the services offered. So aside from the milestones tracker, it has specific strategies per age to promote development and open-ended questions to jumpstart discussions with the families. Let's now have a quick review of the milestones expected in select ages based on this updated CDC milestones checklist. Babies can already see and hear you at an early age. At 2 months old, they calm down when you speak to them or pick them up. They look at your face. They smile when you talk or smile at them. They make sounds other than crying, and they should be reacting to loud sounds already. They watch as you move, looks at the toy for some seconds, and when placed on prone, they can hold up their head already. At 4 months, they are more interactive. They now smile on their own to get your attention. They don't just look at you, but they also move or make sounds to keep your attention. They start cooing. They turn their head towards the sound of your voice, and they respond back with sounds when you talk to them. An important milestone at 4 months is that they already have steady head control, and they can already hold a toy like a rattle when you put it in their hands. At 6 months, they know familiar people. They like to look at themselves in a mirror. They they take turns making sounds with you. They stick their tongue out, blow raspberries, make squealing noises. Mouthing is an expected behavior at this age. So the mouthing is very frequent. They reach and grab a toy they want, and they can roll from tummy to back. Let's watch what a 9-month-old can do.
Ayan, very good. Ayun. Step na siya. Okay.
So pincer grasp, they transfer from one hand to another. They bang objects. There's a lot of babbling. They clap and imitate. And they play and enjoy peekaboo. 9 months is a crucial age. Um, they are shy, clingy, or feel fearful already around strangers. They display several facial expressions, and an important milestone is response to name calling. So at 9 months, they should look immediately when you call their name. Absence or inconsistent response to name calling is one of the red flags we see for autism. They make different sounds. They lift their arms up to be picked up. Um, they look for objects when dropped out of sight. They bang two things together, and they can already sit without support. And syempre, yung pinakaiintay ng lahat, yung first birthday. So at this age, they can play games with you. They wave bye-bye, and they call a parent mama or dada already. They also understand no. They pull to stand. They walk holding on to furniture, drink from a cup without a lid, and picks things up between the thumb and pointer finger like small bits of food. They also look for things he sees you hide. Let's watch what an 18-month-old can do.
Go to the chair. Come on. Let's eat breakfast. Come on. Go to the chair and eat breakfast. Come on. Wait for it. What's that? What's that? Monkey. This one. Oh, very good. What about this one? Chloe's fingers. Chloe's fingers. Chloe's toes. Chloe's toes. There you go. Chloe's head. Head. Okay. Eyes. 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 Well, ears, 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 your ears. Very good.
Yan. Medyo nalito na si Chloe, no? 18 months is also an important age. They move away from you, but they look to make sure you are close by. So hindi na sila basta nawawala. They point to show you something interesting, which is what we call joint attention. And again, the absence of this social emotional milestone can be a red flag for autism. They look at few pages in a book with you. They help you dress up. They help in dressing up. And for language, they already say 3 or more words beside mama or dada and can follow one-step commands. They copy you doing chores and they play with toys functionally. Another important thing to monitor is independent walking. So they walk without holding on to anyone or anything. They start to scribble. They drink from a cup without a lid, but still with spillage. They feed using their fingers, and they already try to use a spoon. And then they reach the 2-year-old mark. Let's now watch what 2.5-year-olds can already do.
Lucky dance. Look.
They can go up and down the stairs.
Kick the bottom up. Kick it. Good boy.
Yan. At ang galing-galing na nilang mag-climb.
What's
They can
that?
already
A triangle? You know how to make a triangle?
Put on your mask. It's okay. Sige, later. Eggplant. Eggplant po. That's pliers.
Yan. 2.5. Okay, so they play next to other children or already play with them. Mahilig silang magbida, so they show you what they can do. They follow simple routines like packing up their toys. For language, they say about 50 words. Say 2 or more words with one action word, and they use pronouns. They do pretend play, follow two-step instructions, and may know at least one color. And they already use their hands to twist things, take some clothes off by themselves, let's say loose jackets, jump off the ground and turn book pages one at a time. And marirealize natin ang bilis ng panahon, no? 4 years old na sila. So at 4 years old, they do imaginative play already. They ask to go play with children if none are around. They comfort others who are hurt or sad. They can already avoid danger. They like to be a helper, and they change behavior based on where they are. Language-wise, they talk like an adult already. They speak in sentences. They can say some words from a song, story, or rhyme. They already talk spontaneously about things that happened during their day, and they answer simple questions like what is a crayon for, what is a cup for. Cognitively, they can name a few colors, tell what comes next in a well-known story, and they can draw a person with 3 or more body parts. So at least yung stick figure kaya na nila. For gross motor, they can catch a large ball most of the time, and they can already unbutton some of their buttons and also hold a pencil with a tripod grip. So after maintaining a developmental history, the next step is making accurate and informed observations of the child. Making accurate and informed observations of the child includes a thorough physical examination. So we give special attention to anthropometrics and the presence of major or minor congenital anomalies. This is also an opportunity to observe or check some of the skills expected already for the age. For example, at 9 months old, we can check if they respond to their name, sit without support, or can already play peekaboo with you or with the parent. Fourth step, or fourth component, identifying risks, strengths, and protective factors. A risk assessment is an important part of surveillance. So we have here a list of medical risk factors for possible delays. There are also developmental disorders that have a familial risk. So if a child is diagnosed with autism, there is a 10 to 20% recurrence risk in the next offspring. ADHD and learning disorder are also familial. Environmental, social, and demographic factors can increase a child's risk for delays in development. Multiple risk factors can amplify each other and lead to toxic stress. So, as discussed earlier, toxic stress may negatively and permanently affect the child's development if there are no buffers in place. We take a proactive approach in doing developmental promotion for children at risk, whether the risk is medical or psychosocial. It is also important to have a low threshold in referring them for intervention and further evaluation once delays are present. It is also essential to look for protective factors, and if there's none, we help them build these factors. So these include breastfeeding, early cognitive and social-emotional stimulation, strong connections within a supportive family, opportunities to interact with other children, opportunities to grow in independence with appropriate structure, resiliency in older children, maternal education, quality schools in the area, and faith-based organizations. Even for children who have experienced adversity early in life or diagnosed with developmental disorders, outcomes improve with the presence of these factors. For the fifth component, it's important to update the records. So medical records should document the outcome of all surveillance and screening activities during preventive care visits. So the actions taken, whether we are scheduling them for an early follow-up visit or we refer them already to medical specialists or intervention programs, that should be documented in the records. And for the last component, surveillance is usually performed by the primary care provider, but there may be other professionals engaged with the child. Example, other medical specialists, preschool teachers, or even therapists. It is important that we share our findings and actions as they may help or may have additional inputs about our concerns, and they can also take part in the action plan. And to summarize the process, we do surveillance at each visit. Anytime the pediatric healthcare professionals or families have concerns about their child's development, screening is recommended to help refine the risk. At times, it may be appropriate to bypass screening and directly refer for evaluation based on clinical judgment or let's say the doctor is highly considering a developmental disorder. With or without concerns, we do routine developmental screening at 9 months, 18 months, and 30 months or 2.5 years old. An autism-specific screening test should also be administered with or without concerns at 18 months and 2 years old. And special attention is also recommended at the 4 to 5 year visit to screen for school readiness. If there are any concerns identified, developmental screening is recommended to identify delays before school entry. And anytime developmental screening is positive, we refer for developmental evaluation. If results of screening are negative, we document the findings, we recommend developmental promotion, and repeat the process of surveillance in the subsequent visit. So to end, I'd like to reiterate that pediatric healthcare professionals have a crucial role in the early detection and early intervention of children at risk for adverse developmental and behavioral outcomes. The rapid change in the psychosocial, environmental risk landscape poses additional risk for developmental and behavioral problems. The challenge is to be aware of these risk factors, and the clinical signs, and to take a proactive role in detecting and addressing early issues. As clinicians, even if we're not pediatricians, we can adapt the components of surveillance to assist in the early detection and intervention of children during our encounters with them and their families. As policymakers and child advocates, we can build or support programs that provide buffers for early life adversities and interventions that are accessible and affordable to Filipino families. I would like to end with these lyrics from a famous ad 35 years ago. So, amidst all the unpredictable things happening, let us not lose sight of what is essential, which is the children, our children, and the important role or duty we play in building a better tomorrow for them. Thank you for your attention and enjoy the rest of the evening.
Thank you very much, Rita, for an extensive and relevant lecture. Okay.
Yeah.
Thanks, Rita, and of course, Tina, for your lecture. So now let's go to the interesting part, the question and answer portion.
Yeah.
So let's start with Tina.
Okay.
You ready? So what do you advise mothers who start to
Excuse me, Melissa.
Yes.
But actually, you can also direct your questions to Melissa since she's also a dermatologist.
I'm just a moderator today.
Okay.
So let's ask the first question. What do you advise mothers who start to experience hair loss after pregnancy? And there was a follow-up question, so I'll just connect it now. Are there recommended hair medications after birth to help maintain hair growth?
Okay, so well, I explained to them why they're actually experiencing hair loss. I tell them that I think I mentioned this during the lecture that during pregnancy, their hair strands, most of their hair strands go to or at least there's actually baseline, 85% of the hair strands are in the anagen phase, in the growth phase. During pregnancy, there's an increase in the number of hair strands in the anagen phase. So they get like fuller hair, fuller crown of hair. Now, after pregnancy, when they give birth, the situation reverses and there's more hair strands in the telogen phase. What happens in the telogen phase? That's actually the resting phase before the hair sheds. So if there's an increase in hair strands in the telogen phase, after a while, they experience hair loss. And this lasts for 1 to 5 months, or rather, it starts 1 to 5 months after pregnancy, but may last until 12 months. We tell our patients that after 12 months, their hair may already be back to normal. Now, during the time when they're experiencing hair loss, we tell them to use shampoos that are advertised as hair thickening shampoos. No? Because these shampoos usually have protein that coats the hair and make it appear thicker. And then we also tell them to use conditioners that are for thinning hair, because these conditioners are usually lighter and do not weigh down the hair. I also tell my patients not to put their conditioners on the top or on the scalp, but to apply them on the hair. Again, not on the scalp, so that it will not weigh down on the hair. And also to avoid conditioning shampoos, because the conditioning shampoos usually have, again, heavy conditioners that can weigh down on the hair, and the hair will just appear limp. Another thing that I tell them is to have a different hairstyle. Like if they're used to long hair, to shorten it, because usually, like, isn't it like if your hair is long, just one hair strand, if it falls, it looks like a lot of hair, and the patient panics. So I tell them to get shorter hair. Also, the last one, I actually prescribe minoxidil. So I think this one answers the second question. This helps in hair regrowth. I prescribe minoxidil 3%. This is actually over the counter. The usual dose is 1 ml twice a day. So that if you buy this this minoxidil in a spray form, that's equivalent to 8 sprays throughout the scalp. So 8 sprays in the morning and 8 sprays at night. Yeah.
Okay. Thanks, Tina. I agree with you regarding the conditioner, not to apply it on the scalp and just on the ends. And with regards to minoxidil, I also tell them that there's side effects sometimes, that there's increased hair on the upper lip area. So just warn the patients when they start doing minoxidil. But there are, of course, answers to the hirsutism.
Yeah.
So now let's go to Rita.
Hi,
Rita,
Melissa.
ready? Yeah. So Rita, how can we do developmental surveillance if we are not pediatricians?
Thank you, Melis. So, yun din, no, that's why I'm very excited to talk in this forum kasi hindi lang pediatricians. So, it should not be limited to pediatricians or general practitioners. So, for example, you're a nurse or a midwife working or giving primary immunization, you can track the development of the child and monitor the progress. And if you see any signs of delay or concern, then refer for evaluation. So surveillance is also not just looking for delays. It is really being more proactive. I enumerated all the protective factors. So yun din yung gusto nating i-emphasize. And then, siguro share ko lang, no? So we have sa class natin, in the audience, various subspecialties. That extra step of giving or sharing your observation to parents will be very valuable. So for example, a lot of parents consult an ENT doctor for speech delay, and we do get several referrals from them kasi, di ba, the reason for the speech delay is not really hearing, but primarily developmental. Just to share one incident, I had a parent who had meron na siyang duda about the child, pero siguro in denial pa lang talaga. What really pushed her to seek consult is the child was very malikot, so had a laceration in the forehead. And she said, Doktora, it was when the surgeon who did the laceration, nung tinatanggal na yung suture, shared na may delays siyang na-observe dun sa bata and that evaluation should be done. Dun siya talaga na-alarm. Kasi di ba, it's already the surgeon giving the observation. So in our practice, every time we meet children, that extra step in doing observation will really matter in the early detection and intervention. Yun.
Thanks, Rita. Now we go back to Tina. So there's another question. Actually, it was messaged to me. How do you treat stretch marks from pregnancy? Can it be prevented? And are there any safe stretch mark creams during pregnancy?
Oh, during pregnancy. I don't think there's much evidence with regard to the effect of stretch marks creams during pregnancy as to their effectiveness. So usually we delay treatment of stretch marks until after pregnancy because like for example, tretinoin, we don't really know how safe they are, how safe it is to use it during pregnancy. So we delay the treatment of stretch marks until after pregnancy. We usually see two kinds of stretch marks, striae rubra and the other one is striae alba. So striae rubra is the red type, the red angry stretch mark, sometimes also violaceous. It is the usual initial presentation of stretch marks before they actually become hypopigmented scar-like um, uh, plaques, no, on the abdomen. And when they're hypopigmented, that's striae alba. For striae rubra, the red type, we recommend tretinoin. The higher concentration, the better, usually once a day for 3 to 6 months. If after 6 months there's no improvement, we can tell the patient to actually stop using it. But we may also refer them for procedures, laser procedures, like pulse dye laser, and also fractional laser, and even microneedling. This fractional laser and microneedling can also be done for the hypopigmented stretch marks. Okay.
Thanks, Tina. Agree with all your answers. So now we go back to Rita. So you mentioned that being born during the pandemic is already a risk factor. What can we do at this point to decrease the risk?
Yes, Melis, no. So, if you look at my lecture, diba, there was a slide about psychosocial risk factors. And karamihan doon are present, diba, during the pandemic. Sama pa natin yung mental health of the parents. Siguro yung first is to really be vigilant in terms of monitoring them and being proactive. There are a lot of questions about social media. And I'm sure, diba, ang dami na sa Facebook about no screen time for less than 2 years old. Pero most do not take this seriously. If we look at the core concepts of early development, it's the serve and return interaction. Simplihan natin. Ito yung batuhan. Diba? Pagka nagpipikabu o in Tagalog, sausaw suka. Diba? Kasi patakik yan pagka milestones tracker or eat bulaga. It's when we talk to them, it's when we respond to them that yung builds the neural connections. What happens if naiwan yung bata in front of baby TV, iPad at an early age? Yes, pwedeng ABC, pwedeng colors, but it is really a one-way interaction. So being proactive is really maximizing opportunities for serve and respond back and forth interaction, and being proactive also in opportunities. We hear parents say, kasi doktora pandemic. Totoo naman. Kaya lang kung iisipin mo, life goes on, di ba? Even during the pandemic, hindi naman nag-iiba yung milestone. So in a way, dehado talaga sila. Kaya all the more we should parang help them catch up, mas proactive. Siyempre, best effort yon lagi. And then do surveillance. Kapag may delays, there are also questions about paano kung 2 years old, di pa nagsasalita, pero nakakaintindi. A delay is a delay. Mas mainam matingnan agad para regardless of the cause. Minsan takot because of the diagnosis, but minsan naman early intervention, our aim is really to intervene early. Minsan it's still evolving. So like what I've said, basta may delay, it's very important to have screening and evaluation done regardless kung sa tingin natin mild lang yung problem.
Thanks, Rita. Actually, there's like a comment here, which is good. Dr. Villadolid, MMDST and newborn screening are part of the nursing curriculum. I'm glad you mentioned nurses as part of the health professionals. So thank you. Yeah. That's from Glenda Arquisa.
Yes, and very important role actually.
That's true.
Allied medical. Yes.
Do we still have time for another question? There's another question here for Tina. What is a good emollient for atopic dermatitis?
A good emollient. Is the person asking for a brand?
We know naman. What are good yeah, we cannot say any brands.
I guess just any moisturizing lotions that are fragrance free.
Okay.
Yeah.
Yeah, we cannot mention any brands. So we still have time. One more question, then let's go to the certificate of attend. So how about, I think this is for Rita, how about tantrums on 5 years old? How should we manage to control or to subside their tantrums?
Mm.
Di ba? Ito.
Actually, tantrums naman, kahit nga adult, nagta-tantrum pa din. Di ba? So, it really depends on probably the intensity, the
Walang
frequency.
pait.
Can you mute your mic, please?
Ayun. Yung di lang ako mapait, pati yung ano mapait. Ano may sinabi ko mapait kanina?
Okay. Go, Rita.
Oo. Baka biglang mag-tantrum. Hindi, well, tantrums naman is really part, di ba, of part of the expected behavior. I think it depends on the frequency, the intensity. So usually we look at the ABCs of behavior, what happened before the tantrum, and what were the consequences given. So ang rule din namin, it's really more a positive behavior approach. So parang what to do to prevent the tantrum. So that's also very important. Pero kasi it's a very general topic, kaya mahirap din siyang sagutin in detail. But basically, to check what are the triggers, how we respond to the child, look at the frequency and the intensity of the tantrum to see if it is really a concern. And then if you have concerns, you can ask your pediatrician about the tantrums of your child.
Okay, thank you. Actually, there's so many questions on the Q&A, so we will just forward it to Dr. Tina and to Dr. Rita, and as much as possible, they will just answer it through your emails. So now let's go to the awarding of the certificates. Both of you did excellent lectures, high yield lectures, which are very informative. So now we'll go to the certificate of appreciation is hereby given. Well, this is for Dr. Maria Cristina Filomena Bata for sharing her expertise as speaker on the topic eczema, atopy, and other dermatologic problems of the mother and child during the UPCM class 1997 postgraduate course, UPCM Health 97, Unraveling the Perplexities of Child and Maternal Health, given this 10th day of June 2022 via the virtual platform. These are all signed by our classmates. First, Maria Cecilia D. Alinea, who is the chair of the UPCM 1997 CME committee. Then Dr. Teresa Luisa Cruz, director of UP Postgraduate Institute of Medicine, UP College of Medicine. Then, of course, our UPCM class 1997 president, as always, Juan Antonio Maximiano Escano. And is also signed by the chair of the postgraduate course, Maria de Briones Palmes, and the chair of the postgraduate course, Efren Balanag. So thank you, Tina. Now for the next certificate of appreciation will be given to Rita Grace Villadolid for sharing her expertise as speaker on the topic Neurobehavioral Red Flags Issues during the UPCM class 1997 postgraduate course, UPCM Health 97, Unraveling the Perplexities of Child and Maternal Health, given this 10th day of June 2022 via the virtual platform. And as the same, it was all signed by Maria Ces Alinea, Juan Antonio Maximiano Escano, Dr. Deb Briones Palmes, and Efren Balanag, and of course, the director of the UP Postgrad Institute of Medicine, Dr. Teresa Luisa G. Cruz. Thank you, Rita.
Thank you, Melissa.
And now for the next part, I turn you over to our closing ceremonies by Dr. Madonna Victoria Domingo, who is the co-chair of the Homecoming Committee of Class 1997. And she is also the director of the University of the Philippines Medical Alumni Society 2022. Where are you, Max?
Thank you very much, Melissa.
Thank you.
Enjoy
Signing off.
We enjoyed your moderating and the lectures that came today. Thank you very much. As we reach the conclusion of our two-day postgraduate course, we would like to acknowledge our moderators who played a large part in the smooth flow of our program and discussions. Here, we are sharing it. We would like to present the certificates of appreciation to doctors. We would like to show them. Dr. Jacqueline O. Navarro, Dr. Yvonne Bernales Mariano, Dr. Susan Villaluz, and Dr. Melissa Pachon Dabao for their invaluable support as moderators for the UPCM 97 postgraduate course entitled UPCM Health 97, Unraveling the Perplexities of Child and Maternal Health, given this 10th day of June 2022 with our distinguished signatory. So thank you very much, classmates. We would also like to present this certificate of appreciation to our dear sponsor, Taisho Pharmaceuticals Company Limited, for the generous support as a sponsor to the UPCM postgraduate course signed by the same personalities. This postgraduate course would not have been possible without the inspired work from the head of our organizing committee and UPMAS president, Dr. Ina Crisologo, our CME head, Dr. Ces Alinea, the co-heads of the postgraduate course, Dr. Efren Balanag, and Dr. Briones Palmes. Of course, they were ably assisted by Dr. Len Sanchez Acosta. And we would like to say special thanks to the one-man or one-woman publicity committee that is Dr. Gladys Tanangonan. Again, we would like to express our profound appreciation to our classmate speakers, Drs. Nina Sioson, Dr. Kathy Medina, Dr. Donna Capili, and Dr. Chris Gacoba, who all spoke yesterday. And for our speakers today, Dr. Brenda Zamora, Dr. Vince Faustina, Dr. Retina Batak, and Dr. Rita Grace Reyes Villadavid. We would like to say, I would like to say that I am very proud to be your classmate. Very proud to say I am in class 97 with you guys. Thank you very much. Mga idol kayo. Also, we would like to thank PGIM, the IMS team, and our reliable staff, Sarah and Chat. Thank you very much for all the big and little things that you do. Maraming salamat sa inyong suporta. To all our attendees, thank you very much for joining us for the past 2 days. We hope that you have learned much and the nuggets of wisdom that we have shared in the past 2 days will be useful in your practice. To the Zoom attendees, there is no need to sign the attendance sheet. It is automatically taken in by Zoom. You just have to fill out the evaluation form. However, for the attendees outside the Zoom webinar format, do not forget to click the link to the attendance form in addition to completing the evaluation form posted in the chat box. So if you're outside of Zoom, you need to fill out 2 forms. If you are in Zoom, you only need to fill out the evaluation form. We enjoin you to join us for our other CME activities for the rest of the year through the UP Med webinars. We are doing weekly registration for that, but for those of you who are already part of UP Med Webinars 2022 Facebook page, you may view it there for 48 hours. So stay safe and have a restful night to all of you. To our classmates, please check our Viber group and each of your emails for the link to the UPCM Batch 9 Class 1997 Fellowship. Please wear your class shirts. Thank you very much for joining us. God bless you all. Thank you.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough, your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.
We created the country's biggest brand when it comes to the small ones' fever and pain. Presenting our paracetamol syrup, Tempra, with no shake formula. You can also help the small ones feel much better with our new and big fever fighter partner, Tempra Cool Touch. It has 10 hours cooling effect to help them keep cool from night until morning. Viva Light Electrolyte Drink. It meets the recommended level of electrolytes to prevent dehydration of children. Temprazin. The small ones can now say goodbye to their sneezing and itchy feeling. Tempra Cough. Your effective mucolytic agent that has a delicious and unique taste. We are here to help these small ones live life stronger to face the big new world they will soon live. That is the big idea.
From Taisho.